students. So this top session will be covering an important bacteria, that is Mycobacterium tuberculosis. So the topics we are going to discuss is morphology, the acid-fast property, pathogenesis, clinical features, complications, lab diagnosis, treatment, and prophylaxis of tuberculosis. So tuberculosis is actually very familiar to all. So the organism which causes tuberculosis is a Mycobacterium group or Mycobacterium genus, which contains several mycobacteria, but the most important one is Mycobacterium tuberculosis. So this is a very frequently asked question, essay question regarding tuberculosis morphology, pathogenesis, laboratory diagnosis, and prophylaxis of Mycobacterium tuberculosis. Frequently asked, so we have to learn everything about this organism. And another short note which is asked from this portion is tuberculin test, which is a skin test which we have learned in the hypersensitivity reaction, type 4 hypersensitivity. So classification of Mycobacterium tuberculosis was a previously asked question. So how will you classify Mycobacterium? It can be classified basically into Mycobacterium tuberculosis complex, which share certain properties. All the mycobacteria which comes under MTB complex share certain properties, similar properties in the appearance of the organism, in microscopy, in culture, in reactions, biochemical reactions and all. And the other group is Mycobacterium leprae, which causes leprosy. So leprae is the causative agent of leprosy. And then you have the non-tuberculous mycobacteria, or they are called as atypical mycobacteria. So non-tuberculous mycobacteria is also called as atypical mycobacteria. So this is basic classification: MTB complex, Mycobacterium leprae, and also the non-tuberculous mycobacteria. So what are the members of the MTB complex? There comes our most important member, Mycobacterium tuberculosis. In addition to that, there is a mycobacterium which resembles tuberculosis, but it is present in animals. It's a zoonotic infection, mainly cattle. So Mycobacterium bovis, that is another one. And there is another one called Mycobacterium africanum, capre. All those are the members of MTB complex. So don't forget Mycobacterium tuberculosis and Mycobacterium bovis. So when you describe the morphology of Mycobacterium tuberculosis, so we are going to learn everything in detail about Mycobacterium tuberculosis. So this organism, it's very slender. It will be like this, very slender, straight or slightly curved with a beaded appearance. When you do the staining, you will see like this. It won't be uniformly stained. It will be non-uniformly stained. So it will be having a beaded appearance. And its size is like 1 to 4 microns. And the most important property of Mycobacterium is it is acid fast. Acid fast means this organism, its cell wall is having a certain peculiarity, which we'll see it in the next slide. Because of that, it is resistant to most of the stains. Most of the stains are not able to penetrate the cell wall, cell membrane of Mycobacterium. And so we need a very strong stain. And once you do staining with a very strong stain, you know what happens? It is resistant to acid and alcohol. Even if you put a strong acid or alcohol into this particular organism, it will resist decolorization. The stain which has entered inside won't go outside. All these property of Mycobacterium is due to some content in its cell wall called mycolic acid. So that is why it is having the name Mycobacteria. All Mycobacteria has got mycolic acid in its cell wall, and that is responsible for the acid-fast staining property. So this organism, it's non-sporing, non-capsulated, non-motile, and it's an obligate aerobe. Remember, Mycobacterium tuberculosis can grow only in the presence of oxygen. It cannot grow otherwise. So the antigenic structure, so morphology, we have seen it's a slender, slightly curved bacilli and having acid-fast property. And this cell wall antigen and structure is also important. You have to remember, you can see this is the cell membrane. Actually, it is having a gram-negative type of cell membrane. You can see the cell membrane, the peptidoglycan layer. But in addition to this, it has got actually gram-positive kind of cell wall it is having. Not gram-negative, it's having a gram-positive kind of cell wall. But in addition to the usual gram-positive cell wall layer, like it is just peptidoglycan and gram-positive, no? This is having an additional arabinogalactan layer, mycolic acid layer, and a lipoarabinomannan layer. So the most important of this is mycolic acid, which is a waxy lipid layer. Actually, mycolic acid is a waxy lipid layer, that is responsible for the staining property of Mycobacterium. So basically it is having a gram-positive kind of cell wall, but in addition to that, it has got this arabinogalactan and mycolic acid. Don't forget mycolic acid. So, uh, how does this Mycobacterium tuberculosis causes the disease tuberculosis? So that is very important. So tuberculosis is one of the very old ancient disease which was once called as captain of all men of death because it was responsible for the death of millions and millions of people before the discovery of this bacilli. And it causes two kinds of disease. The most favorite organ for Mycobacterium is lungs. So it causes pulmonary tuberculosis, and but at the same time it can cause a number of extra pulmonary kind of disease, extrapulmonary lesions. So how do you get tuberculosis? The mode of infection, we know mask will protect against tuberculosis, isn't it? It's actually having a similar kind of mode of transmission like the coronavirus. So it is through inhalation of the infected droplets. So it's a droplet transmission. Inhalation is the mode of infection. So the important thing in tuberculosis pathogenesis is cell-mediated immunity plays a major role in the pathogenesis of tuberculosis. So it is not just because of the bacteria, but it is because of the cell-mediated immune response which tries to arrest the growth of bacteria that leads to lung tissue damage that leads to tuberculosis. So when we learn hypersensitivity, the type 4 hypersensitivity reaction, we learned that the example is tuberculin skin test. Actually, in the pathogenesis of tuberculosis also, it is the delayed type hypersensitivity reaction that is responsible for the pathogenesis. So when TB bacilli enter a person, it can elicit cell-mediated immune response, which can lead to both protective immunity and also delayed type hypersensitivity reaction. So basically the CD4 helper T cell which gets activated in any kind of infection, when an antigen presenting cell show the antigen to a helper T cell. So this is the antigen presenting cell. It has engulfed the TB bacilli. The TB bacilli has entered into this APC, and this APC is going to present this antigen to a CD4 T cell. CD4 T cell is your helper T cell. The CD4 T cell will secrete a number of cytokines which are interferon gamma, interleukin 2, and TNF alpha. This in turn will activate the macrophages. So the macrophages get activated on response to these cytokines. So these macrophages activation is important in the tuberculosis pathogenesis. So here you can see this is what you can write when it is asked for exam pathogenesis in the form of a flow chart. So the mode of infection is inhalation of droplets. After that, what happened? The bacilli will reach the alveoli, and in the alveoli, they are engulfed by the alveolar macrophages. So that is what I told you. Macrophages will engulf it. It will try to do phagocytosis and destroy the bacteria. But TB bacilli is more smarter than the macrophages. They can resist phagocytosis because certain cell membrane contents like arabinogalactan, lipoarabinomannan, they can resist phagocytosis. So as a result, what happened? They survive intracellularly. They won't get destroyed and they will multiply, and they are presented to the helper T cells. The helper T cells will activate all the cells. So but the time when it multiplies and the number increases, it can rupture the macrophage and come out and infect more macrophages. So in this time, the cell-mediated immune response will be coming to action, and the T cells will get activated, macrophages will get activated. At that time, what happens is the activated macrophages, they will aggregate around the bacilli. See, if this is the bacilli present at the center, you can see the macrophages getting aggregated. They become large, giant cells. And they also will attract other cells like the fibroblasts, lymphocytes, everything. All these will together form a granuloma. Granuloma is actually formed by activated macrophages. What they're trying to do is they're trying to contain the bacilli within so that the bacilli won't get disseminated to different organs. So that is very important in the pathogenesis of TB, granuloma formation. So this primary lesion which is formed in the lungs, so here there is a granuloma formation, there is neutrophils, everything coming to this area, it will cause some inflammation. So this primary lesion which is produced in the lung, it is called a Ghon's focus. The Ghon focus along with the hilar lymph nodes. So when there is a lesion here, it will be draining to the hilar lymph nodes, right? So the hilar lymph nodes plus the Ghon focus is called as the primary complex. So this is the primary lesion that happens in any kind of infection, and there is granuloma formation. So what does this granuloma do? It will try to kill the bacilli. What happens is at the center, the active macrophages will be releasing cytokines which will cause cell death at the center. So there will be a caseous necrosis. There will be cheesy material formed within the granuloma. There will be caseation or destruction of the cells inside the granuloma, trying to kill the bacilli. So in this necrotic environment within the granuloma, the oxygen tension will be very low. So TB bacilli cannot survive inside. So the TB bacilli growth will be inhibited in the necrotic environment, and that will lead to destruction of the bacilli. Later on, this lesion will heal and it will get calcified. This is the common sequelae of tuberculosis that occur in most of the people. The TB bacilli, it is controlled within the granuloma. It gets killed within the caseous necrosis because of low oxygen tension. It's an obligate aerobe. It cannot grow without oxygen. So it gets killed, and thus the bacilli is destroyed. The lesion heals and the patient has no problem at all. Just they will be having some calcified opacities in the lung. This is what normally happens. But in some proportion of people, you know what happens? Some bacilli, one or two bacilli will remain within the granuloma. If this is the granuloma at the center, most of the bacilli will die, but one or two will remain within the granuloma. So they causes the latent infection. Latent infection means they are remaining silent, they won't cause any problem, but at a later point of time they can get reactivated. So that is what happened in latent infection. So the most common sequelae is healing of the lesion. The second sequelae is latent infection. The third sequelae is sometimes if a person is immunocompromised, his macrophage activation is not proper, he's having very virulent bacterial infection. In that case, macrophage activation is not sufficient to destroy the bacilli. So the granuloma cannot contain the bacilli. The granuloma will rupture. It will release the bacilli. You can see in this figure, it will rupture. It will release the bacilli, forming a cavity in the lung. This bacilli will enter into the airways and it can go up and come out and infect other people. It can go to different part of the lung, same lung and different lung. It can enter into the blood vessels and to the lymphatics, and it can disseminate to different organs. So this is what happened in disseminated tuberculosis. It's called a progressive TB. Okay, so this happened in certain proportion of people. And in other group which has gone into a latent infection, they can get a reactivation or reinfection at a later point of time, which will elicit a delay type hypersensitivity reaction, and that can lead to secondary tuberculosis, or it's a post-primary tuberculosis. So these are the different sequelae of tuberculosis. So when you write the pathogenesis of TB, don't forget these terms, go and focus: primary complex, granuloma formation, and central caseous necrosis, which will try to kill the bacilli, and latent infection that happens in certain other people. So this is what we discussed: the different sequelae. A primary TB, it will heal and calcify. Some people it will go for a latent TB, and in some group there will be a progressive primary tuberculosis, and in other group who has had a latent infection at a later point of time, when their immunity comes down, or when they get a reinfection with the bacilli, re-exposure to the bacilli, it can lead to a delayed hypersensitivity, exaggerated response of the in the lungs, leading to tissue damage and causing post-primary or secondary tuberculosis. So primary TB can heal and calcify. It can go for a latent infection, which at a later point of time can lead to secondary TB. And in certain other group of people whose immunity is very low, even a primary TB can progress, forming cavitation and fibrosis and dissemination and all. And in any case, if the TB is disseminating to different parts of lung or different parts of body, you call it as a miliary tuberculosis. So you can see the caseous necrosis inside, the TB bacilli getting inhibited here. Sometimes the granuloma can rupture and releasing this bacilli, causing cavitation of the lungs, and patient will become infectious. So you have to know the oral manifestations of tuberculosis, because TB is a very common disease in our country. We account for most of the share of the number of cases of the world. When you take the total number of cases in the world, the most share comes from India. We are endemic for tuberculosis. So TB can have any kind of manifestation. I told you it can be pulmonary and extrapulmonary. So oral lesions in TB you should be familiar with. Tongue is the most commonly affected part. Other sites of palate, buccal mucosa, lips, gingiva, and floor of the mouth. So any part of the oral cavity can be affected. How does it present? It presents as an irregular, painful ulcer. And diffuse inflammatory lesions and fissures can happen in certain people. And tuberculous osteomyelitis of the maxilla or mandible at a later stage. So these are different oral manifestations of TB. Mostly present as an ulcer. It can lead to fissures It can lead to osteomyelitis and all. So the two immunological responses that occur in a patient infected with TB, one is the anti-tubercular immunity. That is, the person will have immunity against that bacilli and he will completely recover. The second one is tuberculin hypersensitivity. In that case, it can progress to TB or it can lead to a latent reactivation at a later stage. So delayed type hypersensitivity, it can be induced in a person by infection with virulent or avirulent tubercle bacilli. So when do we go for an avirulent tubercle bacilli? It is the BCG vaccination that we mean. So post-vaccination or post-infection, one can develop a delayed type hypersensitivity response. So if he develop a delayed type hypersensitivity response, it leads to the TB disease. So infection is different, disease is different. No? Infection means you get exposed to. If your body develops disease, there is damage to the body tissues called a disease. So how do you demonstrate this delay type hypersensitivity in a patient? It is by the tuberculin injection. That is what we learned in the hypersensitivity reaction, by injection of the tuberculin protein. Another term that is Koch's phenomenon, Robert Koch discovered TB bacilli in 1882 and that was a Nobel Prize winning discovery. And Koch has actually studied the TB pathogenesis in guinea pigs, and a combination of hypersensitivity and immunity was noticed in guinea pigs when he injected the virulent TB bacilli in a guinea pig. At a later point of time, that healthy animal died after 2 weeks of the disease, developing nodular ulcerative lesions and all. And when the same guinea pig was once injected with an virulent bacilli, and then later on a virulent bacilli was injected, the animal didn't die, but it developed a shallow ulcer which developed into induration, erythema and all. So that is actually delay type hypersensitivity leading to immunity. The other one, it is leading to the disease. So in either way, the TB immunological response in TB can be in either way. It can be an anti-tubercular protective immunity, or it can be a delay type hypersensitivity leading to tissue damage. So Koch's phenomenon is actually a combination of hypersensitivity and immunity. It's a response of a tuberculous animal to reinfection. That is what is actually called as Koch's phenomenon. Coming to the laboratory diagnosis, so we have learned pathogenesis. The next important part is lab diagnosis. Basically, we have the microscopy, culture, and molecular methods available for diagnosing TB. So you should know what are the specimens that you collect for tuberculosis diagnosis. It's pulmonary is the most common form. So sputum is the most important specimen. You have to take 2 sputum samples. So when a person comes with suspicion of TB, you have to take a sputum sample at the spot and you ask them to bring a sputum sample next day early morning. So 2 samples are required. If sputum is not available, you can go for bronchoalveolar lavage and all. Suppose it's an extrapulmonary TB case. The most common form of extrapulmonary TB is lymph node TB. So if it's a lymph node TB, you go for a lymph node aspirate. If it's a meningeal TB, you go for CSF culture. Bone TB, you have to take the aspirate or joint synovial fluid. If it's an oral ulcer lesion, you have to take the biopsy or the tissue from the ulcerated lesion. So those are the different samples we take. So that's what I told you. Sputum 2 samples, BAL, laryngeal aspirate, and gastric aspirate you take for children. Young children, they won't expectorate sputum. They will just swallow it. So you have to go for gastric aspirate in case of pulmonary TB if you suspect in children. Extrapulmonary, as we have discussed, lymph node aspirate, CSF, synovial fluid, urine in case of renal tuberculosis. So all those are the different samples that we take. So the most important microscopic method which is well accepted is Seal-Nielsen technique. The staining property of tuberculosis was actually this acid-fast staining was first discovered or first introduced by Paul Ehrlich. It was modified by Seal and Nielsen. That's why it's called a Seal-Nielsen staining. So what you do, we have learned in the morphology class about acid-fast staining. You apply concentrated carbon fusion. That is the stain we use. Concentrated, it's a very strong stain, and you apply heat. So heat will help in penetration of the stain through the mycolic acid layer. So the bacilli will get this is a pink color stain. So the bacilli will get this pink color. So the bacilli get the stain. Now you add 25% sulfuric acid to decolorize. But the TB bacilli, Mycobacterium, will resist decolorization. It will retain the pink color stain, whereas everything in the background will lose the color. So second, you have to give a secondary stain. What secondary stain you give? You give a methylene blue stain. So methylene blue stain is the secondary stain. So the background will get the blue color and your bacilli will be appearing as pink color. So this is acid-fast staining or C-Nielsen staining. So the bacilli will appear as pink, slender, beaded bacilli. I told you this bacilli, it's not uniformly stained. It will be looking like this, very slender, beaded bacilli. So other than this C-Nielsen staining, we can also go for a fluorescent staining where you do fluorescent microscope. We need a fluorescent microscopy and you apply fluorescent dyes like auramine and rhodamine. It will look like this, a greenish background and yellowish color bacilli. Now, before doing culture of this specimen, you have to do concentration technique. A concentration of specimen has to be performed. For that, you go for a method called Petrov's method, where you apply N-acetyl L-cysteine is the chemical that we use. It's called NALC, and sodium hydroxide also added. What is the purpose is you want to homogenize the specimen. The specimen should be homogenized, and you have to decontaminate, destroy all other bacteria present except Mycobacterium, and you have to concentrate the specimen. So for that, you add this chemical and you do a centrifugation, you collect the centrifuge and then you add sodium hydroxide. So that is how you perform the concentration method. Now the best thing for culturing TB, the best widely accepted culture medium is the LJ medium, that is called Lowenstein-Jensen medium. And why this is this green in color, a beautiful green color, is because of the dye malachite green. And this medium contain egg. We have learned enriched medium, enriched medium containing blood, serum or egg. So the egg-based medium, we have learned this example, LJ medium. And there are additional things like asparagine, mineral salt, food, nutrition, and glycerol. These are the constituents of LJ medium. You incubate this medium for 37 degrees Celsius for 8 weeks because TB bacilli will take 4 to 8 weeks for growing. Because you remember in physiology of bacteria we learned TB takes 20 hours for multiplication. The replication time for TB is 20 hours, whereas it is 20 minutes for the normal bacteria. That is why it takes such a long time, 4 to 8 weeks. So once the growth appears, you know how the growth looks like. You can see here, it will be dry, rough, wrinkled colonies. You call it as rough, tough and buff colored colonies. That is the description for TB bacilli, rough, tough and buff colored colonies. And the biochemical reaction we do for Mycobacterium tuberculosis, niacin test and nitrate reduction test, that both the tests are positive. Now we have certain automated culture methods available like MGIT. MGIT means Mycobacterial Growth Indicator Tube. And we have BACTEC, that is a commonly used automated method, which will give a faster result. In less than 2 weeks, you will get the cultures positive if you do automated culture. And we have molecular methods like PCR and Gene Expert or CBNAT. What is CBNAT? It is cartridge-based. It's a kind of PCR, but you do it in a cartridge-based nucleic acid amplification technique. That is what is CBNAT. Advantages, in less than 2 hours, you can know whether TB bacilli is present because it is going to detect the genes present. In addition to that, you can also know resistance to rifampicin. Rifampicin is a drug we give for TB. If it is rifampicin resistant, that can also be picked up by a CBNAT test. That is the advantage of CBNAT. This is being commonly used nowadays. Now coming to tuberculin skin test, so that we have already learned in hypersensitivity. This is for detection of, why you need to do tuberculin skin test is detection of latent tuberculosis. I told you one sequelae of TB infection is latent TB. Why you need to detect latent TB? They have a risk of getting a secondary TB at a later point of time. Similarly, tuberculin skin test is also used for diagnosis of TB in children. Suppose skin test is positive in children, you take it as a TB disease. If it is positive in adults, you take it as a latent TB diagnosis. So the most commonly used test for tuberculin skin test is Mantoux test. You have also another kind of test called Heave test, which is not commonly done. So you should know the procedure of Mantoux test because this is a short note asked for the previous year question. So Mantoux test, what you do is 0.1 ml of purified protein derivative. It's actually tuberculin antigen containing 1 tuberculin unit of PPD RT23. That is the antigen we use. It's nothing but a tuberculin antigen of 1 tuberculin unit. It is injected intradermally into the flexor aspect of forearm. Just like how you give the test dose of medicines, this is injected into the flexor aspect. And what you will notice is you will ask the patient to come back after 48 to 72 hours. And then you see whether they have developed an erythema and induration. You can see that here. If it is more than 10 mm, you consider it as positive. It's not just redness, there should be some induration. Then only you consider the test as positive. So if it is more than 10 mm, you consider it as positive. This is because when this person has already been exposed to TB bacilli, now you're injecting tuberculin antigen into the skin. He develops a delayed type hypersensitivity reaction, and that is why at the local point there is kind of induration and erythema that is happening. So when will you get a Manto test false negative? If the person is immunocompromised, there won't be any kind of cell-mediated immune response. So then in that case, the reaction will be negative, but still the person may be having latent TB. In miliary tuberculosis also, the cell-mediated response will be very weak. And false positive, this false negative very commonly seen in HIV people. People have got very high risk for co-infection with TB. False positive, it is seen in atypical mycobacterial infection because they are very close relatives, both mycobacteria, so you can get a false positive reaction. Uses of Manto test to detect latent TB, to measure the prevalence of TB in community, to diagnose active infection in children. I told you in young children, you consider this as TB disease, and it is used as an indicator of successful BCG vaccination. Post-vaccination also, you have to get a tuberculin skin test positive. Basically, the most important use is to detect latent tuberculosis. Now we are going to see what are the anti-tubercular drugs. You have to know just the names of the anti-tubercular drugs we use. We have bactericidal drugs which will completely destroy the bacteria, and bacteriostatic drugs which will just inhibit the growth of the bacteria. So the cidal drugs are rifampicin, isoniazid, pyrazinamide and streptomycin. We commonly put it under the letters HREZ ES. That is what you call the different drugs by different alphabets. H is for isoniazid, R is for rifampicin, Z is for pyrazinamide, E for ethambutol, and S for streptomycin, of which only E is the bacteriostatic drug. All others are bactericidal drugs. So rifampicin, isoniazid, pyrazinamide, and streptomycin. And remember, ethambutol is a bacteriostatic drug. And ethionamide and cycloserine are second line drugs. We can just remember the first line drugs. And how do you give the treatment? You give a treatment for an intensive phase where you give 4 drugs, HREZE, for 2 to 3 months. And in continuation phase, you give 3 drugs, HRE. That is how you treat. So total of at least 6 months treatment is required. 2 months intensive phase and 4 months continuation phase. And MDR TB means the TB bacilli which is resistant to rifampicin and isoniazid. If they are resistant to H and R, you call it as multi-drug resistant TB. And finally, coming to the prophylaxis or prevention of TB, we have a very good vaccine which we administer to all children at birth. At birth itself, you administer this vaccine to babies. It's a live attenuated vaccine that's called BCG vaccine, Bacilli calmette guerin, named after the people who discovered it. And this is derived not from Mycobacterium tuberculosis, but by its relative, that is Mycobacterium bovis. It's a Mycobacterium coming under the same complex. So you administer this vaccine 0.1 ml intradermally soon after birth. This gives protection for at least 10 years. Actually, we are protected from a disseminated TB disease. You are not protected from infection. You can inhale TB bacilli at any point of time, but it won't become a disseminated disease in children because the antibodies will neutralize this bacilli. So the contraindication, it is a live vaccine. Even though it is attenuated, all kind of live vaccines are contraindicated in immunocompromised individuals and also in pregnant females. So contraindications are immunocompromised state and pregnancy. And what are the complications of BCG vaccine? It is fever, local abscess and lymphadenitis. Those are the complications. So we have a control program in India for control of TB. It is called the Revised National Tuberculosis Control Program. They decide on the diagnostic strategy, treatment strategy, everything. And you give TB under a regime called DOTS, daily observed treatment short course or supervision, that is called DOTS. So we give the drugs intensive phase, continuation phase, everything is given under monitoring. So once more, the important question is an essay question. Mycobacterium is very important. So please be thorough with the morphology, pathogenesis, laboratory diagnosis, and also learn everything about tuberculin skin test. Thank you.